Okay,
Thank you,
Dr.
Dr. Sharma. It's been a pleasure to be collaborating with Dr. Sharma for many years, and every year we have to add one or two slides to update this presentation. So you will get a handout at the end of the class. It has bunch of multiple choice question and the answer is at the end, so you could test yourself, and if you see that you need to study, then you know to know which part to study. So what I will do, I will try to summarize and go over the whole most important information today is essentially the units of what's rad, rem, and sievert and gray, and how do you change between them. Radiation protection principle is time distance shielding. You know that, but we'll have to go briefly touch it. A lot of principle, where does it come from? Which one of them is your best friend? Monitoring of radiation protection and exposure in the cath lab. Pregnancy, suppose you love your job and you get pregnant. How do you monitor your fetus? Shielding in the cath lab, what's available and what you could add to decrease the exposure in the cath lab, how to reduce the exposure to the people, how to use the machine properly, um, how to reduce the dose to the skin of the patient so you will not have problem with down the road. And some of the requirement by Joint Commission and recommendation by NCRP, ICRP. So we try to touch base with all these issues. Absorb dose, you've heard of it, is the energy deposit per unit of mass. They call it absorbed dose. And the units that we use in United States still is rads, and 100 rads is 1 gray. If you take rads and multiply by quality factor, what's quality factor is the degree of the damage of the type of radiation. For you, it's all X-rays, so always quality factor is 1. That means REM and RAD is the same, sievert and gray is the same. You follow me? So quality factor for your purpose is 1. SI unit, if you have to change between the units, it's always 100. A typical exposure is lung, about 10 milligram. A chest X-ray, dental X-ray is about 300 milligram. A CAT scan, 2,000 to 3,000 milligram. Average annual reading for a nurse in a hospital, it's about 70 milligram. But a pilot gets 700 milligram. A flight from New York to Philippines is about 13 milligram. These are the typical exposure that we get in our lifetime. How about occupational? Someone who works in a waste disposal facility gets about 1.2 rem or 1240 millirem. Someone who works in a power reactor gets 330 millirem. But the two issues that you have to compare, someone who works in a broad medical institution like a nurse gets 70 millirem, but a pilot gets 700 millirem in 1 year. So question is, what is it about the job of the pilot got 10 times more radiation than a nurse? Anyone? The pilot is always at 30,000 feet. So the more you go higher, the background radiation gets higher and higher. If you look at NCRP 93 and NCRP 160, that's pamphlet or scientific publication refers to what's average American gets radiation in 1 year. So it used to be 360 milligram. Then 30 years later, 2009, they came up with another reference, and that became 620 milligram. Average American gets in a lifetime, every day, every year. So the question is, what changed to be double the amount? And you could see the red one. You added CAT scan, you added nuclear medicine, you added interventional fluoroscopy. These are the information, these are the radiation added to average American exposure. Do you follow me? So if you're writing a grant application, the background radiation to average American is not 360 anymore, it's 620. Or if you're reviewing some exposure to a patient, average background is 620 now, not 360. This is a typical exposure in a cath lab, right? You could see in the bed, right above the bed, the patient get 3,000 milligram per minute, not per hour, not per week, not per month, per minute. So you have to be very, very careful how much scatter away from the patient to you, right? So scatter is always 90 degrees from the patient. At 3 feet, by factor of 1,000 goes down. So if you are 3 feet away from the bed, you get 1,000 times less, which is 3 rads per minute, right? I'm sorry, 3 milligram per minute. Then you go away 6 feet, 9 feet, and diminishes much, much rapidly. Now, how do you monitor who gets how much radiation? We give these badges. It's on the badges says the department, the name, what period you have to wear, what type of a badge. You also have ring badges. This is mostly for people who manipulate radioactive material in their hand, like nuclear medicine department. How to use the badge is very simple. Use it at the end, return it to a place that you have to return. You cannot share. I'm using it Monday, you use it Tuesday. No, there is no such a thing. If you work in 2-3 hospital, I recommend to have each badge, each hospital have their own badge for you, because if something happened, then you don't know where you got the exposure and how to investigate. Do not use it in other institutions. Store the badge in a place that there is no radioactive material and you do not get exposure. This is very important. 99%, this might appear in your exam. How much occupational, how much radiation you are allowed to get per year? Whole body 5,000 milligram, organ 50,000, lens of eye 15,000, skin 50,000. Average lifetime, how much you are allowed to get by your age, is your age multiplied by 1,000 milligram. Any question? This slide is very, very important. Question for you. Among all of these, which one is the most important for you as a cath lab operator? Whole body or lens of eye? Very good. Why? Because you have lead apron, so your whole body is protected. Am I right or wrong? So the lens of eye becomes important unless you have these lead eyeglasses. If you have a job as a cath lab operator, but you get pregnant, so you could declare your pregnancy. It's not mandatory, it's voluntary. It has to be in writing. The fetus cannot get more than 500 milligram in 9 months. But we cannot wait for 9 months to see if it's above or below. So we do it every month, right? And in any months, you cannot go above 50 milligram in 1 month. Question for you. How much was the dose rate at the bed of the patient? 3,000 milligram per minute, remember? This is 50 in 1 month. Do you see how difficult it is to maintain that, right? So if you are pregnant, it's not that you cannot do the job. You have to be very, very careful. You might have a case that emergency, you have a patient who is pregnant, not the operator, that the patient is pregnant, and you have to treat and save the life, right? So the question comes, what do you do? What kind of risk you adding to the child or to the gestation period? And this is an excellent slide for you to have it, because it's explained to you what risk associated with what gestation period, 2 weeks, 8 weeks, 10 weeks, to the fetus. Of course, you are not going to irradiate the fetus area 99% to the chest area. Am I right or wrong? However, there is a scatter from here to the belly. So it's a good slide to have. At the end of the year, each person who works with radiation gets this, they call it Form 5 or annual report. Each column or each box has its own information. If you have any question, ask your physicist or radiation safety officer. ALARA stands for as low as reasonably achievable. It simply means that radiation, we don't know what kind of effect it's going to have on you, so keep it as low as possible, right? How do you implement it? In practicality, we say if one of you or any of you gets more than 10% in 3 months, then you pass the ALARA level 1. Then you become notified. Someone notifies you, you pass ALARA 1. If you pass 30% of your annual limit in 3 months, then you are in ALARA level 2. And we investigate to see what went wrong, why you are in ALARA level 2. Has any of you been ever investigated by radiation safety about your ALARA or contacted by it? It's very simple. You just ask a few questions to make sure that this is a normal part of your job. These badges, in some institution, how do they monitor you? In some institution, they give you one badge outside the apron. In some institution, they give you 2 badges, one under, one outside. The problem with 2 badges is that if it gets switched, the whole calculation goes wrong and your exposure completely makes no sense whatsoever. So as we move forward, most of the institutions, they are going to 1 badge outside the apron because we could calculate how much outside you will have under the apron. It's very easy. There have been so many papers published about it already. Originally says that if you have exposure outside the apron, by factor of 3, it will be under the apron, less. So you divide by 3.3 and you get what's under the apron. So they did the studies and they came back that it was overestimated. This estimation of under the apron was overestimated, and they recalculated, and the NCRP 122 published that it says it's factor of 5.6, not 3. Do you follow me? So 5.6, we've done a lot of work in Mount Sinai, and it's very, very accurate. For the two dosimeter method, you say 0.04 times the color plus 1.5 times, and it's a different formula. But in Mount Sinai, we use 1 badge outside the apron, and we calculate by dividing 5.6. If you get lead eyeglasses, I recommend it. It could reduce it by 98% the dose to the eye, lens of eye. However, how do you know if this lead glass is real or fake, right? Because if you buy it for $10, $15, I guarantee you it's not lead in it. And we did that. Some of the people, they bring it to the hospital. We put it under the fluoro, and you will see there is no lead in it at all. So you get the wrong feeling that you've been protected, but you are not being protected at all. So if it's too cheap, that means it's not lead. How about the exposure to the operator? There has been many publications that you could see the type of procedure, how much exposure per microsievert the operator gets. annual effective dose to the operator, and there are references, and these are per 1,000 procedure per year. So you could estimate or go through it and see, look at this slide more carefully. What are the typical exposure that you will be getting annually? There was in 2011 ICRP publication that says that for cataract formation, they used to think is 2 gray was the threshold. Now they think is half a gray will create cataract. So that means you have to be more careful protecting your eyes. In the same year, there was a ICRP publication that says that the limit in the United States is 15 rad per year. However, in Europe and other parts of the world, they recommended 2 rem per year, average over 5 years, but nothing more than 5 rem per year to the single year to your eye. So if you go to England tomorrow, the limits are the last line to your eye. If you are in the United States, the limit to your eye still is 15 rem per year. You follow me? So what they did, they proposed to United States, this is the limit, do you accept it? And I remember every hospital has to make a vote. And at the end, NCRP decided, no, we are happy with 15, I'm sorry, NRC. NRC decided we are happy with our limit because we do not see so many operators getting more than 15 rep. You follow me? And in fact, there was a paper published in China. They looked at 3,000 interventional people, and they saw that the number of the people that exceeded 15 rem was 0. So that's why in China they keep 15 rem limit too. There was also publication by Joint Commission that says that the dose that you give to the patient has to be recorded, has to be saved somewhere. So 6 months later, a patient come back to you and say, Dr. Jones, how much radiation did I receive? You cannot say, oh, I don't know. No, you have to give it to him. So since then, all the machines that you buy, if you buy a new fluoro machine, automatically saves the patient dose. Do you follow me? I remember at one point, some of the machines, they were old, we had to write it with our hand, the dose to the patient. Now they have this dosaver that measures how much radiation you give to the patient. Joint Commission also says that if you give more than 15 gray to the patient, to the skin of the patient, you have to report it. And also they said that it has to be retrievable format, which is PAX units, right? NCRP 102 says that if you want to enter a cath lab, you have to have a lead apron. If you are not needed in the cath lab, don't go in the cath lab. And if you are in the cath lab, try to stay behind the shielding. And the lead that you use in a cath lab has to be less than or at least 0.25 millimeter lead equivalent. Anyone knows why they say lead equivalent? Because there are other materials that you could use that they are not lead, but they are denser and thicker and more flexible. The basic fundamental of radiation protection is time, distance, shielding. Time, reduce the time. Distance, you increase the distance. And shielding is what you put between you and the source of radiation. If you look at many angiography, you will see in the public literature that there are so many incidents that people, they come back with this skin injury. So the question is, how do you stop it? How do you prevent? If you look at this case, you will see after 4 to 6 weeks, it came back. Then 16 to 21 weeks, it disappeared. Everybody thought that it went away, thank God. No, but then after 21 months, 18 or 21 months, it came back. So they had to do a skin graft to take care of this case. Another case is 53, it was 2007, a 53-year-old man had diabetes with a stent replacement, and he had chest pain on his way to Thailand. And on April 2008, he returned to East Asia in hospital, and he had 5 hours of fluoroscopy procedure. So the red area and this silver color area you see is the cream, because from the pain of the burning skin to calm him down. They've done studies that they said 20% of the dose that you give to the patient is when you are not looking at the screen. So if you are not looking at the screen, please do not push the pedal. This is one of the most important slides in this lecture, because it comes from dermatologist who is familiar with skin injuries. If you look at the x-axis is the time after the incident. If you look at the y-axis is how much radiation you give to the patient. But if you look, you will see between 5 to 15 are the majority of your problem as a function of time. Do you follow me? So that means that you should try to stay below 5 gray. Now, NCRP 168 recommended that this table, that if you stay, let's say fluoroscopy, you could pick up any of them. Up to 30 minutes, fine. Above 30 minutes, every 15 minutes, you have to inform the operator, hey, be careful. Do you follow me? And if it's more than 60 minutes, then become SRDL, which is substantial radiation dose threshold. So in Mount Sinai, we decided to have our own level, and we used 5 gray and 7.5 gray. 5 gray, we informed the patient. 7.5 gray, not only we informed the patient, we asked the patient to come back to check for injury. Is that everybody gets that? If you do long cases, you have to be familiar with these limits and NCRP. After implementing these level that I told you, you will see this is a result of Mount Sinai Cath lab, how much radiation to skin dose have decreased. And this is remarkable because the blue is the total number of the patient and the red is number of the patient above 5 gray. That's remarkable. Now, what dermatologists tell you what to be careful. 0 to 2 gray to the skin, you will not see any effect. 2 to 5 gray, you will have possibly erythema, that means reddening of the skin. 5 to 10 gray, you have to advise the patient to check themselves if there is any reddening. 10 to 15 gray, you have to follow up. You have to ask the patient to come back. And above 15 gray is follow-up is essential because you definitely, for sure, you will have skin injury. Now, if you summarize it, you will have 3 parts how to prevent it. Before you see the patient, during the procedure, and after. Before you ask some question, have you had any fluoroscopy procedure? Have you had any stent replacement? Any of these questions. Then during, I will show you how to reduce the dose to the patient during, and after, I told you how to recall or ask the patient to come back. So there are very important issues. It's 3, 4 slides you have to remember. One is a scatter from the patient's body is the greatest to the source of. So if you stay close to the tube. So they summarize it to 2 easy rule. When possible, stay as far as possible from the patient. 2, for lateral projection, stand on the II side, not on the tube side. This is the result of it. You will see if you stay on the II side, the amount of exposure to your eye is much, much less. Minimize fluoroscopy time if possible. Keep the patient as far as possible from the tube. Modify the tube angle during the procedure if it's possible for spread of the skin dose. Grid should be removed. Do not use grid. Refrain from boost if possible. Use last image hold. Use collimator. Use electric magnification. Use pulse. What else? And if you forget any of these I told you, look at www.imagegently.org. So this organization started 10, 15 years ago, and it's not only for Cath lab, for CAT scan too, and they are very, very serious about patients' dose. If you want to summarize it, this is a slide to summary of what will affect the patient dose. There has been many discussion about cataract. There are many, many reasons that a person could get cataract, but one of them is radiation, ionizing radiation. If you look at the life expectancy of loss of life for many different reasons, you could be a male and smoke 1 pack a day, you lose 2,400 days of your life. If you are smoking and you are a female, you lose 1,400 days of your life. If you work in a radiation area, you get 1 rem per year from age of 18 to 65, you lose only 51 days of your life. So are you worried to work with radiation compared to smoking? All I'm trying to tell you that there are many worse in your life. There has been many, many papers published about back pain and lead apron. You could look at it, many publications, and they came up with 42% of the cases they have developed back problem. And what happened is now the Organization for Occupational Radiation Safety Interventional Fluoroscopy, ORS, have you heard ORSIF? Now, ORSIF has a white paper that they're trying to reduce or find a paper to find a way to reduce the patient dose, not patient dose, operator dose. So ORSIF is worried about you, not the patient. Do you follow me? But the question is, where is the radiation come from? From the patient scatters to you. So if you reduce the patient dose, you're reducing the dose to yourself. But following ORSIF white paper that it says not only you will have back problem, you will have cataract and so on and so on, the question has come up lately, can I get rid of my lead apron? The answer is, if you look at the regulation, you must have it unless you have radiation protection equipment around so you don't get exposed. Now, what's available? Have you seen these before? Zero gravity, 80,000. This protects only 1 person in the Cath lab. This was rad pad, you saw that. Those has to be checked. This is another one. Egg nets has come up. They claim 97% of the dose to the whole room, not just 1% to the whole room, because all these panel around the patient and on the top stops the radiation to anywhere in the room. Some institution, they have checked into it, and I think 20 or 25 of them already been sold around the United States. This one is Rampart, is just a panel, that movable panel. The problem with this is that it's not the whole room. It doesn't reduce the radiation to the whole room, only part that the operator sits, you follow me? But it's also 600-700 pounds each panel, so you have to be extremely careful you don't get damaged. But this is another one. Another one is radiation. It came up recently, and people are checking into this 90 to 95% reduction. And Protego is another one that it goes higher, but it's movable around the bed. So these are your choices if you are interested and you're going somewhere and the hospital has money. It ranges around 100 to 250, these equipment. And once you have the radiation 1 year before and 1 year after of using any of these, then you see that you are not getting more than 500 milligram in the whole year, then you don't need to have lead apron. Do you follow me? But you have to have 1 year of data at least to make sure that you are doing correctly. If you have references, you need references, these are all references. And if you have questions, I'll be happy to answer your questions. Thank you again.